Now doing more and more of these cases. We're now a lead UK centre for a multi-centre European randomised controlled trial. We're a key centre in the International Cartilage Repair Society UK Clinical Trials Group. And we're just putting together a package where we're going to apply for government funding for a big trial to look at trying to do this, this type of repair treatment more efficiently and in a better fashion. The National Institute for Clinical Excellence reviewed these types of new technology. They're certain that further basic science research is required. And that's part of my basic science program, is looking at that. And I'm interested in what affects the cartilage itself. Why do you get damage? Or how can you influence it? And it's partly its mechanical environment, and it's partly growth factors or substances from the body which talk to the chondrocytes or the cells, and they either behave in a good way or a way that allows them to be destroyed. So you can perhaps manipulate that with medicines. And that's part of the work I do with Philippa Hulley and Richie Gill, is we're looking at load and the action of load and growth factors and the action of drugs and medicines to try and understand that. How do patients help us do that? Well, patients agree to allow us to use parts of their bone, of the cartilage, which we take at joint replacement surgery, and allow us to study these things in more detail. And without this patient engagement, and people allowing us to be able to do that, we couldn't do that type of work. So I want to just emphasise to the people who very kindly come here tonight how grateful we are for people's involvement. And time again, our patients will allow us to do this type of research, which is a huge advantage to us. Lastly, I want to pick up on something which is a more recent piece of work that I'm involved in. Again, with David and the rest of those guys who you saw in the list. So, if we start to have treatments for early arthritis, how do you identify people who have early disease? So these are patients who, again, in their 30s and 40s, are busy people working, have knee pain, may have significant disability. When you take an X-ray, you might not see anything. So here's an X-ray of a patient who had a large lesion in their knee, which is debilitating and causing them real problems. If you just went on the X-ray alone, you wouldn't know that. So we needed in some way to study a group of patients who would allow us to try and understand how you might find these defects earlier. And I want to tell you a little bit about some work we did where we looked in our patient groups at people who are at high genetic risk of developing osteoarthritis. Because if we identified that group of people, we could focus our attention on studying them to see if we could find early lesions or early disease. So let me show you, perhaps many of you may have been involved in this type of research. Interesting to ask you afterwards, is that we have many patients who are proband. It's a technical term we use. It's a patient who has a condition, and the condition is this type of arthritis. And that type of arthritis you might find in their brothers and sisters. And so we've looked at large groups of our patients and matched them to find within your brother and sister, if you've had a joint replacement or you've got that disease, if you have brothers and sisters, they are at higher genetic risk of developing the disease. If you then look at their offspring, so you study the children of people who have a high chance of getting osteoarthritis, you'll identify patients, and this is a sort of demonstration of how the genetic risk is transferred down through family lines. You can get a demonstration of a 4 times greater risk in certain patient groups of having osteoarthritis. And we've been able to do that, again, with the help of our patients. We've identified people at higher risk. You can then study them to look for early and partial thickness disease. So not the end-stage disease, which is seen on X-rays. Perhaps I'll demonstrate that to you. If you look at this timeline for knee OA, the end-stage disease, which is bone on bone, is typically seen on an X-ray, and that's pretty understandable. You wouldn't miss that. If you look for this early OA, or partial thickness, now this is perhaps just as symptomatic, and we don't necessarily know the right way to treat it, If you use MRI technology, you might understand how there's a progression in these X-rays. You can see it, from osteoarthritis on the left through partial thickness to the one on the right where there's no problem. If you take an MRI and you focus in on certain areas of the MRI, what looks normal on the left-hand screen is abnormal with an MRI. And our technology for identifying these lesions is getting better year by year. And so that sibling patient group who I wanted to share with you, because again, it's the patients who've helped us do that, have been vitally important in making these sorts of moves forward. And actually, this is the sort of patient who I would want to treat with my autologous chondrocyte implantation techniques. So you see how the two things come together. More basic science research has allowed us to identify patients more easily. Perhaps more interestingly, even beyond that, is trying to find patients who don't have any changes when you look, if you ask them how their knees are. So there are groups of patients who have no symptoms, but have the earliest disease problems. And there are newer techniques with MRI to try and discover which patients have early changes within their knee. And this is right at the cutting edge of basic science research in trying to find cartilage lesions. And this is very exciting. So I just want to leave you with two summary points before David takes on presentation. That really we're trying to improve our cartilage repair methods, and that's to try and improve our care for younger patients before they develop the end stage of arthritis and they need a joint replacement. And we're trying to improve our ability to identify patients, and we're doing this with better imaging techniques such as MRI. So thank you very much.